Добрый день. Ну и теперь мы переходим к нашей рабочей программе. Достаточно серьезная программа. И, конечно же, я думаю, что это будет нам очень интересно. Первый доклад, который называется «ОКТ. Ангиография при заболеваниях сетчатки», докладывает Мурат Хасан Рейсаглу. Он доктор медицины, associate профессор отделения офтальмологии медицинского колледжа университета Гази, город Анкара, Турция. Пожалуйста.
Chairman, dear colleagues, good morning. I am Dr. Murat Hasan Reisoğlu from Gazi University Ophthalmology Department. First of all, I would like to thank Professor Bigbo for his kind invitation, and also I would like to thank and congratulate Dr. Professor Duman for this great achievement, and also I would like to thank Dr. Gelişken for his extraordinary efforts in the process of realization of this session. I'm going to talk about the optical coherence tomography angiography, but I would like to emphasize that this subject is a very broad and growing area of interest, and in this talk particularly, we will just take a glance to this broad subject, and we will not go into details. Optical coherence tomography angiography, as I said, is a very exciting new imaging technology which uses motion contrast to provide uninvasive image of retina and choroid. It's based on acquisition of 3D volume OCT scans viewed end phase to provide details of the vasculature at any level of retina and choroid. It uses signal decorrelation in between sequential transfers, OCT's cross-sectional B scans, which are acquired from the same retinal location. And then the rationale behind the OCTA imaging is that static tissues, like non-moving tissues, reflect the same signal like the stationary signal, and repeated scans will be identical. In the vasculature, because of the moving erythrocytes, the reflected signal are not stationary, so also the scans are not identical. The change in between those scans are analyzed and processed to give the final OCTA image. After OCTA image, after that is amplified by various amplification algorithms, such as SSADA, and also digital processing is applied to provide an en-face view of the retina. Also, motion correction technologies and artifaction removal technologies are applied to further improve the image quality. In an attempt to simplify the 3D volume in the OCTA scan, the 3D volume scan is then split it into slabs, which are in the OptoView machine 4, and called inner retinal slab, middle retinal slab, outer retinal slab, and choriocapillary slab. The inner retinal slabs extends 3 microns below the ILM to 15 microns below the inner plexiform layer, which this layer incorporates the superficial capillary plexus, which we generally see on the traditional fluorescein angiography. Middle retinal slab extends 15 microns below the IPL and to 70 microns below the IPL. This layer incorporates the deep capillary plexus, which is poorly seen on traditional fluorescein angiographies, but very well observed in OCTA imaging. It's already providing insights into pathology of some diseases like parafoveal telangiectasia, paracentral acute middle maculopathy, and retinal angiomatous proliferation. Outer retinal slab is extending from 70 microns below the IPL to 30 microns below the RPE level. This layer in normal individuals has never any vasculature. It's very useful to detect type 2 neovascular membranes. Choriocapillary slab is 30 micron below to the RPE. It starts from there and extends 60 micron below the RPE. And it's particularly useful in the early detection of type 1 neovascularizations. There is the basic principle of in order to understand the basic principle of OCTA imaging, one should understand that the intensity of the vessels which we visualize on the printouts of the OCT scans are the reflection of the amount of blood flow, which has a minimal threshold, also has a maximum threshold, which is called the saturation limit. What it means that if the blood flow is slower than the time between the B scans, then it will be interpreted as the absence of flow. And if the blood flow is faster than the maximum threshold limit, then the signal will be interpreted always the same and not more whiter or anything. So there is also no leakage, no staining, and no blockage in the OCT imaging. This lack of leakage can be interpreted as a disadvantage. However, it can be also an advantage, as true anatomy is not obscured. As all imaging modalities, OCTA also has its own limitations, like small sampling size, the largest being 8 by 8 millimeters on most of the commercially available OCT machines. Also, when the sampling size increases, the quality of the image also decreases. The OCTA has also lots of artifacts like motion, projection, shadowing, and segmentation artifacts. There is ongoing effort to cancel or improve these artifacts. One of them is the projection artifact removal provided by the AngioView software. But all these artifact removal tools has its own disadvantages also. Now, at the second part of my presentation, I would like to give examples on use of OCTA imaging technology in several major retinal diseases. But I'm not going to go into detail. First is the neovascular AMD. OCTA is particularly useful detecting neovascular membranes. As all you know, type 1 neovascular membranes originates from the choriocapillaris and grows under RPE, and often they are associated with PEDs. If it is associated with pigment epithelial detachment, it's often difficult to detect with conventional imaging like fluorescent angiography. OCTA provides detailed assessment of the microvascular morphologies of these vessel complexes, which are typically hidden under these PDs. Here is an example of the patient which fluorescent angiography didn't show any leakage, just staining of the drusenoid PDs, and then OCTA beautifully demonstrated the type 1 neovascular membrane. At the early stage, OCTA shows type 1 neovascularization as small tangled web of fine vessels or round tuft of small caliber capillaries in the absence of an associated dilated core feeder vessel. But chronic stage is markedly different from the early lesion findings. OCTA demonstrates large, mature vascular complexes, branching vessels from a core trunk composed of one or more large dilated feeder vessels. It is defined, the shapes are defined as C-fan or medusa morphologies. OCTA is also useful to detect the blood flow related to recalcitrant vessels within the fibrotic scar. Large, mature vessels without an associated fine dense of capillary plexus, large flow void areas or dark halos of the choriocapillaries are seen. This pattern is called dead tree morphology. Type 2 neovascular membranes, as all you know, originates from choriocapillaries and located above the RPE in the subretinal space. OCTA demonstrates these lesions as oval globular structures consisting of high flow vessels. Flow void areas are usually seen around the lesion at the outer retina and choriocapillaris. A large feeder vessel is typical, as seen in this patient. That's usually the piercing vessel through the RPE, and is observed as a large fetal vessel here. Type 3 neovascular membranes are proposed to represent the intraretinal location of neovascular lesions. OCTA defines them as retinal anastomosis that emerge from the deep capillary plexus and creating a high-flow, tuft-shaped neovascular lesion at the outer retinal segmentation level. Choriocapillary segmentation may show a small clue-like lesion corresponding to the tuft-shaped network just located above the neovascular lesion. Polypoidal choroidal vasculopathy is a variant of neovascular AMD, and it's now considered as a form of type 1 choroidal neovascularization, which is composed of polyps with or without branching vascular networks. The branching vascular networks are seen as high-flow lesions on OCTA imaging. On the other hand, polypoid lesions can appear as hyperflow or hyperflow round structures. It depends on the turbulent flow or hemorrhage in the polyp. ICGA still seems to show the polyp complex better than OCTA, except those branching vascular networks observed on OCTA imaging. Central serous chorioretinopathy is another example of disease entities where OCTA is particularly useful. In the acute phase, increased choroidal flow and the dark area of apparent flow reduction can be observed just under the serous RD. This may be due to light attenuation artifact and compression of choriocapillaris. In the chronic central serous chorioretinopathy, irregular choroidal flow patterns are observed, but the main contribution of OCTA is the choroidal neovascular membrane detection. Choroidal neovascular membranes share the common features as retinal pigment epithelial detachments, subretinal fluid, and intraretinal fluid, as seen in central serous lesions. But OCTA can clearly define the neovascular membranes as seen in our patient here. Adult onset vitelliform dystrophy can show non-specific features on the OCTA imaging. However, the OCTA imaging has the ability to visualize the CNV, which is hardly visible on the angiography and ICG angiography due to the masking effect of the vitelliform material. In diabetic retinopathy, OCT angiography has a great potential because it can show the superficial capillary layers, deep capillary plexuses, and also it has the ability to make volumetric scans and then segment them. OCTA can demonstrate all lesions except leakage. Macroaneurysms are well demonstrated, but they are there is inconsistency between fluorescein angiography and OCT angiography. It may be due to the flow parameters inside the macroaneurysms. Also, diabetic macular edema is very well shown on the en-face image of the inner plexiform layer. Ischemic diabetic maculopathy changes are well observed in the OCT images, such as enlargement or irregularity of FAZ area. Also, quantitative mapping, such as vascular density maps, non-flow area maps, can also be made using OCT angiography. Retinal artery occlusions can also be visualized on OCT imaging, and there is improved visualization of retinal macrovasculature. More precise, there's also OCTA images can provide more precise demarcation of non-perfusion areas. The main advantage of OCTA over the fluorescein angiography is the choroidal flash absence, which is seen in fluorescein angiography. Also, deep capillary ischemia is outlined more precisely with OCTA angiography, as seen in paracentral acute middle maculopathy. Retinal vein occlusions also can be assessed using OCTA imaging. The enlargement of the FAZ, macular edema, capillary non-perfusions are very well documented. Also, secondary changes, remodeling processes such as vena-venous collaterals and retinal neovascularization processes are well demonstrated. MACTEL type 2 is another example where the OCTA is very useful. At the early stages, it shows the dilation of superficial and deep capillaries, enlargement of the intercapillary space, and also it shows a dilated temporal high-flow capillary venules. The microcysts seen on OCT also corresponds well to the small capillary voids at the choriocapillaris level on OCTA imaging. But it's more useful in the advanced stage where a foveolar avascular zone is direct temporally, and also it's useful in detection of subretinal new vessels in the neovascular stage of the disease. I'm not going to talk about the OCT imaging details of the uveitis or inflammatory conditions, but I can say that white dot syndromes are very well defined in the literature, and they are shown to be very well correlated with the ICGA imaging, except one condition, which is mute. A multiple evanescent white dot syndrome definition has changed after the OCTA evaluation, where its definition is defined as an RP and outer retina disease because no choroidal ischemia was observed in the OCTA imaging. Also, we can assess the decreased flow, especially in the deep capillary plexus in the vasculitis cases. Vascular occlusions are easily detected, and automatic evaluation of the quantitative data, such as vessel density indices, flow indices, are extremely useful when monitoring the treatment response to the uveitis, treatment response of the patients. The major disadvantage of this OCT imaging is that leakage cannot be detected due to the extravasating cells are the leukocytes instead of erythrocytes, and there's a low leakage flux. At last, the major contribution of OCTA imaging is the detection of inflammatory choroidal neovascular membranes in uveitis patients. The characteristic finding of a choroidal neovascular membrane on fluorescein angiography is the early hyperfluorescence, which can be masked by inflammatory components such as exudations or hemorrhage. Also, RPE defects caused by the inflammation, such in the cases of multifocal choroiditis or PEEK cases, they can show early hyperfluorescence, which can mimic as pseudo choroidal neovascular membranes. OCTA shows the true anatomy, and it has the ability to delineate the choroidal neovascular membranes. Here, as you can see in our patient, where the peripapillary inflammatory choroidal neovascular membrane is observed. To conclude, OCTA offers a number of advantages to clinical retina practice. The exams are quick and easy to obtain. Several limitations such as artifacts and small sampling size are likely to improve with technological advancements. Academic validation is still ongoing, and I would like to thank you for listening to me again. Thank you.
Вопросы после этого. Спасибо большое. Thank you very much. Я хочу напомнить участникам, что вопросы задаются, можно передавать в президиум в письменном виде.